free for all. Anybody got a cool study that you want to pitch? You've got a nationwide, worldwide audience. Anything out there you really think they should go on or steer them towards?
Well, I think that the whole world of PARP inhibitors is making good segues into this disease and
find the HRDs, get them on those studies.
Absolutely, and there are few PARP inhibitors that seem to continue to move forward in oncology, but also more so in pancreas cancer now. Olaparib, rucaparib, talazoparib, and others as well. Veliparib, has been relatively disappointing. I mean, the whole premise of developing Veliparib was about
So PARP inhibitor study, get in one.
Yes, a good one.
But remind everybody, it's what, 11%? We saw that slide the other day.
Well,
it's a small percentage of people. So obviously we need, PARP's great, but we need to do other work.
I would say 3 to 4%, or 5%, 8%, 10%. It's all over the place, but nonetheless, anything above 1% is worth looking for.
Any other
because
studies
the difference
that you
is
think
pretty
are cool out
significant.
there going forward?
The Abraxane, the nab-paclitaxel gemcitabine adjuvant, that's going to be really interesting, especially with the data presented today. How are we going to decide which treatment to use? Are the numbers going to be similar? Patient selection, again, I think that's going to change how we treat patients, especially in the adjuvant setting.
And it's an international study, unlike, again, the FOLFIRINOX studies have been consistently French studies, whereby the nab-paclitaxel studies have been more international. So there are certain variabilities in how you can interpret or cross-compare.
Although the adjuvant trial had a Canadian contribution, a significant Canadian contribution.
Yes.
So we'll say it's North American.
We're throwing everything at immunotherapy plus whatever else you have in your garage. And do you see some promise, some hope, or is it let this mature a bit before moving forward?
I do. I think if there's a path forward for immunotherapy for the broad patient population, it's going to be combining upfront with chemotherapy and then maybe de-escalating. So there's a nice example. The Parker Consortium is looking at CD40 agonistic antibodies and checkpoints combined with chemotherapy, 1 and 2. And then there are several examples of other studies. I think the CSF1R data in pancreas cancer in combination with nivolumab look interesting. That's being explored in a second-line randomized phase 2. The Morpheus platform has multiple arms, and we'll get some hints. We'll learn.
Yes, it's all about understanding your drivers in your microenvironment, your immunosuppressive versus your immunostimulatory drivers, and you want to suppress the bad, enhance the good. Checkpoint inhibitors by themselves, even if you pile up on the checkpoint inhibitors, are not going to do it. The CSF1Rs are actually very interesting because they bring down those bad macrophages and they essentially allow those good macrophages to start doing their job. But I agree with Eileen too, the challenge remains the same, that all these manipulations will depend on if you can break that barrier, but again, be very careful of how you do it. You will need a chemotherapy backbone.
So the barrier is the stroma. So you've got to affect the stroma.
Part
the
of
drugs
the stroma.
that we have,
it's only part
hopefully
of the
doing
stroma.
That, and hopefully will be done in combination. So that's where I think we're headed.
It's only part of the stroma, right? It's the outside of the stroma.
Choose whether or not you want to give leucovorin. Decide whether the stroma is a positive or negative. But the big picture here is that really breakthrough changing, practice changing in the adjuvant setting, additional data in the metastatic setting that gives us some more help on how best to manage that patient. And I think really you guys have done just a terrific job of summarizing where we are in the next phase, and there is hope, and we have to keep working on this so that we do not stay as frustrated as we are going forward. So you've lived up to this and more, and this has been extremely informative. But before we go, we're going to give each one of our panelists one final thought. George, you get the floor first.
Sequencing. So remember, we've got regimens where we can sequence patients, nab-paclitaxel, gemcitabine, followed by Nal-Iri. That's how we select which upfront regimen we can use. If we go with FOLFIRINOX, lots of management, and then we don't know what to do in the second line. So I think we just have to go back to basics. That's what we have in June 2018. You got to think about the sequencing. You got to think about the FDA-approved drugs, the Category 1 recommended regimens, and all the research will come from Eileen.
Be a smart, balanced oncologist, Dr. Mody.
I would say that multidisciplinary approach to potentially resectable patients, giving them all the options and all the treatment up front, I think the pancreas cancer community, we've done a fantastic job, patients included, of raising awareness for this disease, getting patients in trials whenever possible, wherever they are around you, whatever is practical for the patient to do. I think there's a lot of options in immunotherapy. We've recognized the need to address this in a very comprehensive way, in a multifaceted way, not just a one drug way. And those agents and a multitude of agents are coming, and I think there's a lot of hope.
Dr. O'Reilly.
So I completely echo what George and Kabir have said and endorse all of that and make two additional points. I think access to new agents, we've probably got the ceiling with where we are with the current cytotoxics, and an increased focus on early detection. That's absolutely where we'll make the biggest impact on this disease. That's a challenge. That's a challenge, but...
I hesitate to do this, but the last word, Tanios.
Well, I think I echo everything that was said. I think the most important message that needs to get out is you think about, when you think about your treatment options, think about your patient, don't think about a scan or a biochemical marker or any other markers. Ultimately, we want to make sure that our patients have the best quality of life and quantity of life. It takes a lot of balance. Second point I want to make, done with the leucovorin.
I hesitated. Yeah.
You give Levamisole, is that what you're doing?
Thank you all for your contributions to this discussion, and on behalf of our panel, we thank you for joining us, and we hope that you found this peer exchange discussion to be useful and informative.